Hello everybody, I'm Olof Heimbürger from Stockholm, Sweden, and I will talk about the peritonitis. If you want interested in this topic, please go to the ISPD guidelines, which are published regularly. The last one is from 2016, so I think we can expect the new version relatively soon. When we look at how frequent is peritonitis, we can see data from the PDOPs, which are data from 6 different countries in the world and centers, and on average, the risk of peritonitis was about 0.28 episodes per patient year. That's about a little less than 1 episode in 3 years for each patient. And still, peritonitis is the major cause of modality switch. You can see that on average, 40-70% of therapy switches were due to infection, by far more common than other reasons to stop PD. For the diagnosis of peritonitis, ISPD recommend to use the definition at least 2 of 3 features. That's clinical features with abdominal pain and cloudy dialysate, a dialysate effluent white count that's increased, and a positive dialysate culture. And they also recommend that patients where peritonitis is suspected are treated until diagnosis can be confirmed or excluded. There are also other reasons for cloudy dialysate. Most of them are relatively uncommon, but I just want to point out that the eosinophilic peritonitis sometimes occur quite early in the course of PD. This is a paper from Immunity where they looked at the immune defense in the peritoneal cavity from patients with peritonitis. They used our clinical samples to make basic immunology research. This journal has an impact factor of 22. And why I show this, I just want to point out this, that we have a switch. After about 4 days, when peritonitis is resolving, you can see that neutrophils go down and you get a mononuclear count that's higher. And this is a sign of healing. So if still you have some cloudy dialysate, but it's a switch from polynuclear to mononuclear dominance, then you know that the healing process and resolution of peritonitis is going on. And this is data from the Australian registry, and based on the results of treatment in different centers. And you can see that cure was found in 69% of the episodes. And the chance of cure was higher in larger centers in more PD patients, and if patients were receiving empirical antibiotics, both for gram-positive and gram-negative organisms. And you can see adjusted for organism, patient characteristics, and for patient characteristics, center characteristics, not so much difference between the centers. So it's important to follow the guidelines. But still, they only had 69% cure in Australia and New Zealand. From PDOPs, they had 63% cure. So quite large proportion of the patients that don't have cure, and that ends up in catheter removal, technique failure, or death. And this is data from PDOPs, and you can see here the different organisms. And you can see that particularly Pseudomonas results in a high proportion, both of technique failure, catheter removal, relapse, and recurrence. And the same is for microbial bacteria and fungus, which are the worst. But on the other hand, if you look at less negative staphylococci or streptococci, they are quite low risk of catheter removal. And about the terminology of peritonitis, we talk about recurrent peritonitis. That's an episode that occurs within 4 weeks, but with a different organism. If it's the same organism, we talk about a relapse if it's been 4 weeks. And if it's the same organism more than 4 weeks, we talk about repeat peritonitis. Then refractory peritonitis, that's failure of cure and the effluent to clear after 5 days of appropriate antibiotics. And this is very important because then you need to make action. And also talk about catheter-related when you find the same organism in exit site infection or tunnel infection in the dialysate. And for the initial antibiotic selection, it's recommended that you should cover both gram-positive and gram-negative organisms. For the gram-positive, either a first-generation cephalosporin or vancomycin, and for gram-negative, an aminoglycoside or a third-generation cephalosporin. And this is a quite useful scheme from a paper in Jason from Hong Kong, where they suggest how you treat them. And I just want to point out here that depending on the bacteria, you treat for 2 weeks for coagulase negative Staphylococci and Streptococci, most others for 3 weeks, but you prolong it, for example, for Pseudomonas. And if you have failure in 5 days with appropriate antibiotics, you should go for catheter removal. And this is how you should dose vancomycin. And it's quite interesting because you could use intermittent dosing, or you could use continuous dosing. And you can see that according to ISPD guideline 2005, it was recommended 15 to 30 milligrams per kilo in a dose. That's about 2 grams for a 70 kilo patient. And you should add more if the patient has significant residual renal function. They later removed that in a paper from Lam in PDI 2020. They recommended to increase the dose by 20% with significant residual renal function. And then you should repeat the dose after 5 to 7 days. According to continuous vancomycin dose in the ISPD recommends 30 milligrams per kilo as a loading dose, and then a maintenance dose that's much lower in each bag. What we do in our hospital is that we give 25 milligrams in each bag, and then we don't need to make any plasma concentration measurements, and that's quite convenient and easy way of treating it. And when we look at the pharmacokinetics of intermittent very continuous, it's important to remember that intermittent antibiotic treatment is based on the absorption of antibiotic into plasma and transport back to the peritoneal cavity into the dialysate. And you need to give a dose that loads up in the body based on the body size, and then it's removed in the dialysate in significant amounts, and then you need to base the interval of dosing based on clearance, that's the peritoneal clearance, but also the residual renal function. So very logical that you should give it more frequently if you have a good residual renal function, or you should give a higher loading dose. Continuous dosing is easier because it's based on therapeutic concentrations in the dialysate, because it's extremely rare that peritonitis is associated with septicemia. But if you have a patient that's clinically septic, you need to add intravenous antibiotics as well if you use continuous dosing. And this is just showing what happens when you give it intraperitoneal vancomycin. You get a very high concentration initially and build up in plasma. Then later it dialysate back and you get concentrations in dialysate. And we should also know that when you look at pharmacokinetic data about absorption of antibiotics, that it's the diffusive transport is faster, so you get a faster absorption, and it's for vancomycin it's around 70 to 90% during peritonitis because you have a larger vascular surface area of the peritoneal membrane. And that also means that you have a fast transport into the dialysate in the exchanges in between. This is some data from UK, from Stanley Fann's group, looking at vancomycin concentration after 5 days and 10 days. And you can see, and also gentamicin, where they gave 1 dose every day, as recommended by the ISPD. And you can see that a significant number of patients had antibiotic concentrations in plasma after 5 days that were too low, in spite of giving about 2 grams. And they also, in a separate study, look at the dialysate level of vancomycin at day 5 before the next dose. And you can see that about 23% of the patient had inefficient vancomycin concentration before the next dose. So it's a risk of undertreatment if the patient has a good residual renal function, if the dose of vancomycin is too low. Polymicrobial peritonitis, then it's important to have a surgical evaluation and think about other reasons than contamination as a cause of peritonitis. And it's also important to have different antibiotic regimen and add, for example, metronidazole. And often a computed tomography is helpful in this situation. And now to the 2 case reports. This is a 64-year-old man. He had progressive kidney disease due to diabetic nephropathy. He also had heart failure and hypertension, quite typical patient. In February 2019, he got a PD catheter inserted, was trained for CAPD, and changed to APD in May 2019. He had an exit site infection with Staph aureus, treated with flucloxacillin, which good effect. Half a year later, he had a new infection. He got fusidic acid in combination with flucloxacin. He got a thrombocytopenia from this treatment. He was hospitalized and treated, and the fusidic acid was removed and the thrombocytes became normal. And instead of persistent exit site infection, treated with clindamycin. And then we did what we often do in this situation, we shaved the external cuff. That was quite successful, but they got a new exit site infection. No effect of clindamycin, but this time it grew Corynebacterium, which is not a very common pathogen. But according to the sensitivity, we treated with doxycycline with good effect. And you can see that the staph were quite susceptible to all antibiotics, whereas the resistance for the Corynebacterium. So obviously this was cause of the infection. Later he was hospitalized because of abdominal pain and suspicion of peritonitis, but the dialysate leukocytes were not very high. Negative culture, a CT showed cholecystitis and was treated. And in November, he was hospital because of severe exit site infection and cloudy dialysate. And now, this time, it was very clear peritonitis. Culture for an exit site and dialysate showed growth of Staph aureus. You can see it's sensitive for everything. That's very common with Staph aureus, that it's not a very resistant bacteria, but because of the slime from the bacteria, it's difficult to get rid of it. And what to do? That's a severe exit site infection, the external cuff already removed, and now peritonitis. It's obvious that we need to change catheter. What we did, he was treated both intravenously and perinatal with cloxacillin, because if you give it just IP, you can't treat the exit site infection because the plasma concentration becomes too low. The peritonitis healed. The catheter was removed, and we then let the skin just heal for a few days, and after 3 days, a new the catheter was inserted, started an APD again, and you can see this is a photo of the exit site after, so it worked very well. You can notice that we did this reinsertion of the catheter, in fact, a little earlier, because this ISPD recommend 2 weeks after catheter removal and complete resolution of peritoneal symptoms, but we didn't want to put the patient on hemo in between, and that's why we did it a little early, which was successful in this time, but we didn't really follow the guidelines. And now for the next case report. This is a 53-year-old woman with polycystic kidney disease, treated with APDs in 6 months. This is a cloudy dialysate, and she goes to the hospital. She has a high C-reactive protein, high leukocyte in the dialysate. Peritonitis treatment is started, but the dialysate continues to be cloudy. The CRP protein is increasing. She has a slightly elevated body temperature. We give her intravenous antibiotics as well. The PD culture is negative. After 4 days, the C-reactive is 260. What should we do? The patient is fortunately feeling quite well. I can imagine a situation with similar history where the patient is quite bad, but this patient was quite okay. Of course, we did a CT, which showed the perforated diverticulitis in the sigmoid colon. PD is stopped. We call the surgeon, and we keep the catheter open to see if it gets some drainage, but it's closed. The surgeon asked if it can be used to rinse the infectious site, which of course not, would just spread the peritonitis in the rest abdomen, so we don't do that. Surgery is discussed, but in this case, conservative therapy was successful. And I'm quite sure that if we had rinsed the peritoneal cavity, we would have needed to make major surgery. Now we had growth of bacterius fragilis. Patient was started on hemo, PD catheter removed, and she undergoes further investigation to see if she can later be transplanted. She was discharged, and in this case, we continued on hemo. and she was later transplanted. But you can always discuss if we could have considered to go back to PD, which I think would have been an option. But remember, peritonitis can be other things like diverticulitis, appendicitis, and cholecystitis, which is quite difficult to diagnose. Thank you very much.